Alright class, we're going to start today with talking about chapter 38. This is Patients with Special Challenges. You can look this up in your textbook on page 1290. You should also print the handout, the document off of Canvas, and so you can take notes kind of along with this lecture. Whenever I look at this and I see patients with special challenges, that feels like every patient ever go on. So I feel like every patient has its own special challenge. So we're going to talk about just follow along the textbook, and I'm going to highlight some stuff that's important for you all for the textbook. But just keep in mind, every call you go on is going to have its own special challenges. So anyway, what does this mean? Your textbook kind of breaks it down into sensory impairments, cognitive and emotional impairments. And then at the end of the chapter, we'll have a hodgepodge of other things that you're going to see in the field also. There's no way in my career that I've seen all these, or I ever will see all these. I'm certainly not an expert in all these either, so I can speak from a little bit of experience, and then some of this stuff I'll just be telling you what I've read out of a book. So anyway, coming to sensory impairments, these are things that you will see all the time. When we look at people with hearing impairments, as we get older, our hearing kind of goes away. It gets a little bit worse as we get older, so if you're trying to communicate with someone that has a hearing impairment, check to see if they have a hearing aid. Is it turned on? Is it working properly? It's kind of basic steps, number one. And also face these people. Look at them because they learn to read lips over time, and maybe slow down and talk to them a little slower than what I'm talking to you all right now. So for hearing impairment, you can also look at writing stuff down for them also. Your textbook will have a little bit more tips, and I'm going to remember to tell you also. Make sure you follow along there also. When you come to vision impairment, speak slowly, speak calmly, maybe ask them short in questions instead of long in questions. And then when we come to, hearing impairment, I forgot to mention the sign language too. If the caregiver knows sign language, that may be a good way of communicating with them also. When we look over here as far as speech impairment, speech impairments, there's a whole different, there's a big array of people that have different types of speech impairment. So I would advise y'all to see if they have a caretaker, if they can communicate with them in some form or fashion. You can also show demonstrations on what you're going to do. You can also do writing and visual stuff on a board or whiteboard or a piece of paper or something like that. These can be very challenging patients. Let's say one thing I run in most in EMS is people that don't speak English. And I'm not very good with my Spanish. And so kind of keep that in mind. That's probably the thing we run into most. Sometime last 2 years, I ran a car wreck at 2 a.m. in the morning. And it wasn't just one car wreck. There was 22 patients, every one of them was Spanish speaking, and they had a big pile up over the snow and ice. And that was just one of I could not figure out who was hurt the worst, who needed help. Everybody seemed to be screaming. Everybody seemed to be yelling. It was 6 degrees outside. It was dark. It was really hard to figure out what was going on. We had one police officer that could speak Spanish. So it took us a while to triage this one. But anyway, that's what I see most with speech and talking to people. There's also apps that you can download on your phone that can translate languages, and also the internet has some resources for you too. And there's actually places you can call in now. If you want to subscribe to, your agency wants to subscribe to it, it's an active translator that's available all the time. So anyway, coming on down to your textbook talks about cognitive emotional impairment, and then it tells you to reference mental and emotional to chapter 26. So I don't know why they put this in this chapter, and then tells you to go back to 26 for it, but that's what it does. Okay, so moving on to developmental disabilities. Your old textbook had a whole list of these in here. This textbook just talks about autism, which I found kind of interesting. Autism, I learned a little bit new in this new textbook. It dives pretty deep into autistic patients, and your textbook claims that 50% of autistic patients are nonverbal, and then another 20% of those become nonverbal when they're under stress. So think about that whenever you respond to these patients. They may not be able to talk to you. If they get afraid, they get scared, they're going to kind of clam up and not talk to you also. I've had quite a few of these patients over the years. I do find them very challenging. For me, it's hard to understand what the emergency is, and do an assessment on autistic people is very challenging also. They don't like to be touched. They don't like loud noises, things that they're not used to, not comfortable with, kind of scares them a little bit. So use the caregivers would be my best advice to you. I've transported several autistic people, and for me, I've got to the point where it's like, if it's not a life-threatening emergency, if there's nothing I need to do in the primary assessment, oftentimes I just get these patients on the ambulance, bring the caregiver with them in the back of the ambulance, have them comfort them, and I really don't do a lot of assessment other than just look at them because they don't like me touching them. They don't like seatbelts been put on, been restrained. So I'm trying to keep these patients kind of calm. They also are sensitive to lights and sounds and different kind of sensory stimulation some too. So try to keep your environment calm with these patients. There is a big gamut of autistic patients and what they look like. So I'm definitely no expert on it. I've transferred quite a few of them over the years. That's kind of about all I've got to go on autism. As far as coming down to brain injury patients, I feel like this is such a big box. I worked at a rehab hospital for a year, straight out of college, and I worked mostly with the paralysis patients was my area of expertise, but we did some, worked with the brain injury unit some, and boy, it was just such a wild gamut of patients that we saw. Most of them that I dealt with were from some type of trauma. I thought this was kind of interesting. It's like the 41st dates. We had one patient that had a car wreck in college, going from Florida, and he could tell you his whole life from childhood up to the time of that wreck, and then he didn't remember anything after the wreck. So he came and did therapy with us, and we had a little log. He'd have to open the book up and read what happened the day before, what we did in the last session, because he wouldn't remember anything. He wouldn't even remember my name from day to day. We had other brain injury patients from trauma that didn't speak at all. I remember one that he carried around a box of, it was basically newspapers, and he could sit there, as long as he could twist his newspaper into a cone, he was fine. But if you took the cones away from him, he was screaming, he was yelling, he was violent. Yeah, it's kind of a big gamut of different types of injuries you can have, especially related with trauma. At the rehab hospital, they had an inpatient floor for brain injury, and I thought this was kind of interesting. They had almost like a cushioned room. When they couldn't deal with patients, they would put them in this room, and it has all the walls are padded and the floors are padded, and there was nothing in there. Yeah, I don't know what the science was behind that, but I found that pretty interesting. When they couldn't deal with like a brain injury patient that was acute, they just kind of let them work and tire themselves out in the room, yelling and screaming and kicking and throwing and stuff. Your book does talk about cerebral palsy. Cerebral palsy is a birth defect. Sometimes these present early on, and sometimes they kind of present later on in childhood. These vary greatly on what could be going on with the patient. It depends on where the dysfunction is in the brain, depends on what kind of defect they might have. So just keep in mind this is something you might see out there in the field also. Same kind of thing, you know. It's like you treat all these patients with the same respect you would anyone else. And also, if they got a caregiver, that's going to be your best resource as far as doing your assessment and evaluation on these patients. Coming down to paralysis, different types of paralysis. There's lots of types of paralysis. So we think about trauma a lot and like damage to the spinal cord. At this rehab hospital, this is where I worked mostly at, was with paraplegics and quadriplegics. And these were oftentimes because of trauma. Other stuff we see quite frequently is stroke patients. So a patient that has lost the ability to move one side of their body, which we saw a lot of this at this rehab hospital also. It was actually a really good experience to work at this rehab hospital because I got to see a lot of these patients, which we don't really see that much in EMS. So anyway, coming on down to like paraplegic is going to be they are paralyzed with just the legs. So they usually have function of their arms. Depending on where the injury is in the spinal cord depends on how much movement they have. If you want to look at like a diagram of dermatomes, you can kind of see where their paralysis is going to start. From my experience with these patients, the paraplegics, if they had their abdominal muscles, they still were able to function a lot. They could sit upright in the bed. If they lose their abdominal muscles, they usually have to have a cage around their chest to hold them upright or they'll fall over during transport. And so that's just a little something to keep in mind. If they're paraplegic and they have their abdominal muscles, they're usually pretty capable of getting around, doing things on their own, pretty functional on their own. Things I saw with these patients was getting some type of sores on them because they're always sitting down. So, you know, being cognitive of like the heels of their feet, the bottoms of their feet, their butt, whatever is like the pressure points. We need to keep an eye on those for sores. And also, for these patients, they don't have the ability to control the urine. So they usually have a urinary catheter in. So when you're transporting them, be aware of where that tube's at and don't pull it out. For one, you're gonna have a mess and it's gonna hurt. And also they're really highly susceptible to infections from these urinary catheters that are in all the time. Coming on down to quadriplegics, depending on where this entry is, depends on what you kind of get with these patients. You know, you talk about C3, 4, 5, keep you alive. Well, if you have an injury above like C3, they could be on a ventilator. The diaphragm may not be working, so you may have to transport a ventilator and watch their breathing and respiratory. This can also be very similar to like an ALS patient, Lou Gehrig's disease. I think they mentioned that earlier on in the chapter that I forgot to talk about, but Lou Gehrig's disease is a really harsh disease. It does take your life early. It takes away your nervous system and your ability to breathe, in which case they'll be on a ventilator also. When I first started paramedic, I transported a lot of ventilator patients because I worked for a rural metro for-profit service, and it was very profitable to transport these patients. So I did a lot of these transports with ventilators, and it's definitely challenging. These patients that are on ventilators, they're susceptible to respiratory infections because they have a tube going down their trachea all the time. Oftentimes they have infections, they have extra mucus that needs to be suctioned out, and this is going to be a higher skill than what you are going to be at an EMT to transport these patients to. You all might be transporting a patient that has the injury below like C4, C5, C6, so they can still breathe. These patients, I would say the biggest thing for them that's different from the paraplegic is movement and transport. It's usually going to take 2 people, some extra straps, and the caregiver can really help out a lot with this also.